Hi, welcome to the Slow Fix. I'm Sanjukta Sharma. So this is a conversation with Dr. Anil Sood, one of the world's leading gynecological oncologists. So he's part of the Ovarian Cancer Moonshot program at the MD Anderson Medical Institute and Research Center in the US, which is really the hub of ovarian cancer research around the world. So he was here at Illuminate, a multi-disciplinary oncology conference organized by the Reliance Hospital recently in Mumbai, led by Dr. Sewanti Limaye. So at Illuminate, Dr. Sood presented his recent findings around ovarian cancer. So I had a sort of like a brief discussion with him around this, and in this brief conversation, he sort of talks about the latest that is there to know, what we can expect in terms of treatment and care in the near future around ovarian cancer and other women's cancers. And he also talks about the implications of making the HPV vaccine universal in the goal to sort of eliminate cervical cancer, which is beginning to happen around the world. So let's find out more about gynecological cancers, about ovarian cancers, and what we can sort of be abreast of in terms of cancer care and treatment for women in the near future.
With many of the gynecologic cancers, there's just been tremendous progress in, especially in treatment of different cancers. So, for example, for patients with ovarian cancer, now we know that genetic screening and testing is incredibly important. So all patients with ovarian cancer really should be offered genetic counseling and testing. Because if a patient carries a BRCA mutation or their tumor has an abnormality in that pathway, then they can benefit from being treated with a PARP inhibitor after completing chemotherapy. And for the other patients, certainly there are other opportunities, including drugs that target the blood supply to cancer that can be used in a maintenance setting. So over the last few years, we've learned that maintenance therapy can be incredibly important for patients with ovarian cancer. Similarly, for endometrial cancer, now we know that immunotherapy combined with chemotherapy can be incredibly powerful. There are tremendous benefits in that. Moreover, there are other subtypes, and there's so many new drugs that are coming out that really hold a lot of promise. For patients with cervical cancer, it's been a game changer with the introduction of immune therapy, as well as again, drugs that target the blood supply combined with chemotherapy. Even those with advanced cancer tend to do better. And moreover, for cervical cancer, it's a preventable cancer. So the use of vaccines is certainly an exciting development, but it just needs to be rolled out at a much larger scale. Sure. With a number of cancers, whether it's breast cancer or cervical cancer, there have been screening tests that are widely used. So, for example, mammography for breast cancer, historically, it certainly was a major improvement. And for cervical cancer, you have pap smears and now even HPV testing, and perhaps self-testing is an additional advance as well. For ovarian cancer, it's not for lack of trying. I think a lot of people have tried CA125, ultrasound, but it's just those tests have not been as easy to use on a wide-scale basis, in part because it can also lead to additional testing in someone as well. That's perhaps not as desirable. And for ovarian cancer, it's a cancer that's within a cavity. And so while women do have symptoms with it, the symptoms can overlap with other conditions as well. And so as a result, unfortunately, it's been a harder cancer to screen for. But having said that, there's certainly a lot of new tests that are being tested to see if they can be useful for screening in the long run. There was a large-scale study done in the United Kingdom called the UKC Tox study. And one of the goals was to see two things. One is that can you catch cancers earlier? And there was a stage shift. So you could, if you did screening on a wider basis, you could pick up cancers at an earlier stage. But unfortunately, it didn't really show an improvement in mortality. And part of that may have been just the way the study was designed. Now, the concern, to your point about CA125 is that the scans and so on are one thing, but if it leads to surgeries that carry a real risk to patients, then that can be difficult to justify if you end up doing a lot of unnecessary surgeries and so on. So it's certainly something we need to consider. Is that while CA125 itself may not be a test that we can do on a wide-scale basis, but are there other technologies, and perhaps there might be in the future as more testing gets done. So the Moonshot program, we were charged to launch that about 12 years ago. And our charge was that we needed to come up with a program that would have an impact on patients within a 5-year period. And then over the longer term to discover things that are perhaps not as well known. So I'll give you a couple of examples. We wanted to come up with programs that we could implement almost right away, that we knew were important. So for example, 12 years ago, genetics screening and counseling and testing rates in the country at that point were quite low. They were in the 20 to 30% range, even though the major societies recommended that all patients with ovarian and breast cancer should be getting tested. So we felt that was an important thing to implement. So our metric was that within 1 year, we wanted to exceed 80% of patients getting tested, and we were able to meet that. So that just became standard practice, that really all patients should be getting tested. Then another example was that the care of patients up front was a bit arbitrary in terms of who a patient would see, whether they would have surgery up front or chemotherapy. So we implemented a laparoscopy-based triage system. So for those patients who were candidates for surgery, we felt that a laparoscopic assessment, there was a validated scoring system. And with that, if a patient had a high score, then the likelihood we could remove all cancer was low, and in that setting they would receive chemotherapy. Whereas if the score was low, then the patients would go to upfront surgery. And over the last 10 plus years, of those patients we take to upfront debulking surgery, the likelihood that we can remove all visible cancer is about 90%. So indeed, that kind of a program has been useful in triaging patients appropriately to chemotherapy versus surgery. Those are just two examples. We've carried out a large number of clinical trials and other programs that have really been impactful over this period of time.
And have these technologies gone out to other parts of the world?
Very much so. So even for example, the implementation of laparoscopic assessment, Dr. Fagoti in Rome was actually the one who first designed that program. But since we've been running it, others have been running it, it's certainly been used at many other hospital systems. Moreover, for things that we wanted to discover, where we've done large-scale testing of DNA, of mutations in cancer, or RNA profiling protein, a lot of that data that we've generated, we've made it publicly available to anybody who wants to access that. Undoubtedly, and especially for patients who have a germline, meaning they carry the mutation that can be passed down, or even mutation within the tumor, what's called a somatic mutation, or the HR deficiency in the tumor. For those patients, they've derived tremendous benefit. And now we have data that even with longer term follow-up, these patients certainly have derived tremendous benefit from PARP inhibitors. Where we have to be more careful is in a relapse setting, and especially to perhaps not use PARP inhibitors indefinitely, because there can be real risks with those in terms of the risk of a secondary malignancy, especially when they're used in a relapse setting.
Okay. And how can access to this drug, it's a very expensive drug, be better? There have been generic drugs, and do you think they are as effective, even the generic drugs?
In general, as drugs come off of their patent protection, then the generic drugs, just for example, bevacizumab, which is a drug that targets a blood supply, the generic drugs or the biosimilars are just as effective as as bevacizumab. So I think with PARP inhibitors, similarly, I think we'll see that the efficacy of these other biosimilar drugs, as the original drugs come off of patent, it'll be certainly important for wider access to these.
And when is the patent ending for?
I think with a couple of these drugs, it'll be within the near term, meaning within the next couple of years, that they will start to come off. Ovarian cancer, one of the really important messages is that it's not one disease. There's so many different subtypes of ovarian cancer. But having said that, the most common subtype, high-grade serous ovarian cancer, it's a type of cancer that's incredibly immune suppressed. And so a lot of the traditional immune therapies that have worked well in other cancers have not worked so well against this type of cancer. We certainly hope that as vaccines, CAR T or CAR NK cell therapies get tested, that some of these immune therapies will show promise. But it's likely that we may need to combine these with other drugs that help improve the immune environment in ovarian cancer. Well, let me start at some of the basics first. We know that most cervical cancers are related to the human papillomavirus. I think the vaccine has just been an incredible development, and we know that it's effective. It's effective in preventing, and now there's data in even treating pre-invasive disease. So it's an entirely preventable cancer. So aggressive programs for launching the vaccine or implementing that community-wide is really quite important. But the other thing I would state that it's not just important for girls, that it's really important to vaccinate both the girls and the boys, because otherwise the effectiveness of the vaccine will, number one, be partial. And moreover, we now know that it's not just cervical cancer. Many head and neck cancers, anal cancer, are related to papillomavirus. So this kind of a vaccine may very well have importance for cancers beyond cervical cancer. So in my view, I think it's incredibly important to implement cervical cancer.
And probably even involve communities.
Of course, absolutely. And that's where I think the message will be perhaps easier to get out if we can engage the community leaders. Preventing cancer, we don't know for sure, but we do know that lifestyle of course, it's important, but we need to expand the number of studies where we look at the importance of different lifestyle factors, both pre-diagnosis and after diagnosis of cancer. So at our institution, Dr. Lorenzo Cohen actually has a clinical study in patients with breast cancer where lifestyle changes are implemented in terms of improving nutrition, diet changes, as well as physical activity. Physical activity, I think there's growing data that it's very important, and even those individuals who were not physically active prior to diagnosis of cancer, physical activity in terms of even walking 15 to 20 minutes a day, 5 times a week, can have a huge impact. There will be several messages. One is to be an advocate for themselves. Secondly is to really ask the hard questions and learn about what might be their risk factors, if there's any family history and so on. Third is that really to learn about what might be preventive strategies, for example, the HPV vaccine. For example, birth control pills we know can reduce the risk of ovarian cancer. So just learning about things like that. Then staying engaged with their own healthcare in terms of getting routine exams and appropriate screening, be it with a pap smear or HPV testing, be it with mammogram. And if that can be shifted based on their own risk profile, even better so. So I think there's so many messages around that, but really the biggest message would be to be an advocate for themselves and to engage and really involve themselves in terms of preventing cancer.
Thank you so much, Dr. Anil Sood.
Thank
This
you.
was really insightful. Thank you.
Thank you.
Thank you.